Welcome to Case of the Week, a brief presentation where we explore a case or two that highlights a few salient clinical features that I feel would be immediately applicable to day-to-day practice. Hey, it's Friday afternoon and saw a couple interesting cases today actually that I wanted to share. The interesting thing about the cases that I saw today were that they both had the same condition, but they were at very different stages of their condition. And so I thought it would be fun to just kind of share on video what I saw. So the first case was a friend of mine actually from San Francisco who came over. I've been seeing her for years for this condition. And she actually came over as a LASIK candidate today because she no longer has the condition. And but she wanted me to check for it, which was important. And I did, and she was I was quiet and looked good, and so we decided that we will proceed with LASIK. And then about 10 minutes later, I saw a new patient referred from a colleague in Daly City, actually. And this young man, his late 20s, has actually been treated for 10 years for a dry eye. And the optometrist has been appropriately treating the patient not only with tears but also with very low dose Lotamax, and it's been helping him tremendously. He did send him to a local ophthalmologist who confirmed the diagnosis of dry eye, and they've been trying all sorts of dry eye drops. But the patient just is miserable. He's not getting better. And the condition waxes and wanes. Sometimes it gets a little better, sometimes it gets a little worse. And they just said, hey, really, what's going on here? So I saw the patient. And I asked him, so on a scale of 1 to 10, where are you at right now? He said, about a 4 to a 5, something like that. I said, okay, that's not too bad. And we took a look. And he had a classic condition, which was missed actually by the ophthalmologist and yet picked up by the optometrist, and I was very impressed, and I thought I'd like to share that with you. So the cornea did not stain with fluorescein, but had multiple subepithelial infiltrates throughout the entire cornea. Now each of these infiltrates were slightly different shape and different size, and had the appearance of, I would say, granulated sugar that was gently dusted onto a glass table. And the infiltrates were bilateral and diffuse from limbus to limbus in both eyes. There were no follicles or papules. The lids looked good, and the rest of the cornea looked really good too. And the question comes up, what is this? Why is it not getting better? Why does it wax and wane? And really, what's the best way to manage it? So the first question is what could it be? Well, it can be a dry eye, but not likely. Dry eyes, of course, as we know, have many different manifestations, including diffuse staining with rose bengal and lissamine green, as well as fluorescein. But they don't have subepithelial infiltrates. The next thing is, could it be, say, EKC, adenoviral infection? Unlikely, in that EKC tends to go away after a couple months at the most, maybe a year, even if treated with steroids. And EKC infiltrates are larger and deeper. These were just immediately below the epithelium and elevated. In the acute phase, EKC is accompanied by follicles. That's classically a follicular conjunctivitis. So it really was not EKC. The other question is, could this be herpes? Well, herpes is very, very, very rarely bilateral, and generally does not present with subepithelial infiltrates. The infiltrates in herpes tend to be deeper in the stroma and larger. Well, could it be herpes zoster? Now, herpes zoster can present with subepithelial infiltrates at any time after the condition starts, even 10, 15 years later. But again, those tend to be larger infiltrates and deeper. These are very superficial and I would say granular in nature. So the condition was Tygeson's, and he had really classic signs and symptoms of Tygeson's. So to review, Tygeson's typically can last 5 to 10 years. It tends to burn out after 10 years is actually kind of a long time, but it tends to burn out after 5 to 7 years. But it does wax and wane. Patients can go through times of total comfort, no symptoms, and other times of intense photophobia and foreign body sensation. It can recur a couple times a year, or it can go away and then come back 6, 8, 10 months later, or sometimes it just never quite goes to zero. Now, my friend who I had seen earlier had been bothered by Tygeson's for about 6 years. Hers is completely gone, on no meds, just artificial tears and some restasis. So she is effectively completely burned out. I've seen her for now last couple of years, and she's had no Tygeson's lesions. This gentleman had very active, very symptomatic lesions. He came in on Lotamax and artificial tears. So I agreed with his Lotamax treatment and the tears for comfort. And what I actually did was, he was on Lotamax twice a day, but still symptomatic. So what I recommended is that he bump it up to every 2 hours, and then that we do a slow, very slow taper, maybe over a 4 to 6 week period, always keeping very close eye on the intraocular pressure and whether there's any evidence of a posterior subcapsular cataract. In his case, his pressure was 12 in each eye, and his lenses were crystal clear. And he's been on Lotamax on and off for almost 10 years now. So my therapeutic intervention for him is to increase the Lotamax, bomb it out, and then very slowly taper it. Now, oftentimes they'll need to be on a low maintenance dose, maybe once a day, maybe Monday, Wednesday, and Friday, maybe once a week. It depends. Everybody's different. And then we keep them on either a low dose maintenance dose, or if they become asymptomatic, in the asymptomatic periods, we give them a little drug holiday, keep them off the drugs completely, and if they recur, again, hit it hard, taper very slowly. Anyway, I just wanted to share the case with you. I hope that's helpful, and I'd like to do a case of the week, maybe not once a week, but every few weeks, and hopefully you can find it helpful in your practice. Thank you. Thank you for watching. I hope this was helpful. As always, call or email me with any questions about these cases or other cases you'd like to review. I look forward to seeing you next time.